So part 3 of pharmacokinetics is metabolism, sometimes called biotransformation. The rule on metabolism is that most often metabolism is going to take an inactive drug, converting it into its inactive form. Metabolism is going to convert an active drug into its inactive form. In fact, we can illustrate that in the following slide. So while we often think about metabolism as converting an active drug to an inactive drug, as shown on the first part of this slide, always remember that metabolism can even be an activating reaction, and that's shown in part 2 and part 3 of this slide. In fact, I can take an active drug and form active metabolites through metabolism. There's a note in the margin on benzodiazepines. This is a group that's very classic for forming active metabolites. Drugs like diazepam form multiple active metabolites, and that contributes to the duration of action of those drugs. Remember the third reaction here, where some drugs are prodrugs, which are inactive. Metabolism then converts them to their active form. But the rule is still the rule. Most of the time, metabolism takes an active drug, converts it to its inactive form, and the other two reactions occur less commonly. When we think about metabolism, we talk about phase 1 and phase 2 metabolism. I will tell you that I'm not a big fan of the terms phase 1 and phase 2, and the reason is because it sounds too much like a sequence. Phase 1 and phase 2 sounds like you always have to have a phase 1 reaction before you have phase 2, and that's not true. In fact, this does not predict a sequence of events. I can metabolize a drug by a phase 2 reaction and then metabolize it by a phase 1. I can metabolize it by phase 1 only. I can metabolize it by phase 2 only. So importantly, it's not a sequence. Probably a better term and maybe a better way to think about metabolism is that there are two types of reactions. There's the first type, which we call phase 1, and a second type, which we call phase 2. Phase 1 most often involves enzymes called cytochrome P450s. Cytochrome P450 enzymes are really a number of enzymes. There's about 13 families of P450 enzymes with about 100 enzymes total. And P450 enzymes are going to perform a series of oxidation reactions. In fact, the three types of phase 1 reactions: oxidation, reduction, hydrolysis. P450 enzymes, most of their reactions are oxidations. Remembering that there are a lot of P450 enzymes, this table illustrates just a few of those families, like the 1A2 and the 2C9 and the 2D6 and the 3A4 families. So not all of the families are represented here. We just picked a few select ones to show you in this table. I will tell you that even though this is an important table, it is impossible for you to memorize this table. Now, I understand some of you are out there thinking, I can memorize it. I can memorize anything. But what you can't memorize off of this table are the substrates. If you look at the 1A2 family, we've only got a couple of substrates listed. 2C9 lists a couple of substrates. But look at 2D6. It says many cardiovascular and CNS drugs. We don't even list them all because they're too numerous. And notice 3A4 says 60% of the drugs in the PDR. 60% of the drugs in the physician's desk reference, that's about 700 drugs total that fit into that one box. So maybe the take-home message for 3A4 is that obviously is a very important set of P450 enzymes, because 3A4 metabolizes over half of all the drugs that we have. But there's no way you should even try to memorize any of those. They're just too numerous. So what do you have to focus on in this table? Focus on the concept of P450 inducer and P450 inhibitor. So if I say a drug is a P450 inducer, that drug is going to increase gene expression. It's going to increase gene expression. Let's take an example. If you smoke cigarettes, there are hydrocarbons in cigarette smoke called benzopyrenes. Benzopyrenes are P450 inducers. What I'm saying is this: if you're a smoker, because of those hydrocarbons, you're going to have more 1A2 enzymes compared to a non-smoker. And since I've got more enzymes because of the hydrocarbons in the smoke, Any drug that I take that's metabolized by 1A2 is going to be metabolized to an even greater extent because I've got more enzymes. So let's say you smoke and you take the drug theophylline. A smoker is going to metabolize theophylline to an even greater extent due to more enzymes compared to a non-smoker. Now make that relate to plasma levels. Say it this way. A P450 inducer is going to lower the plasma levels of the substrate compared to somebody who's not on that inducer. So the smoking is going to lower the plasma levels of theophylline, which means in that smoker, I'm going to have to increase their dose of theophylline to get the same benefit. Now, the P450 inducer question, while it's important, it's just not as likely to show up on the test as the inhibitor question, because an inducer is going to lower the plasma level of the substrate. What is the inhibitor going to do? The inhibitor is going to decrease gene expression. And by decreasing gene expression, you'll have fewer enzymes for drug metabolism, and that means the inhibitor is going to increase the plasma level of the substrate. Why is that a more popular question? With higher plasma levels of the drug, you're more likely to get side effects. So pay attention to the inhibitor question. That is the one that is more likely to show up. Here's an example of an inhibitor. If I'm on a macrolide and I'm taking the drug theophylline, now who's a patient that might be taking these two drugs at the same time? Perhaps a patient with chronic bronchitis. If you think about strategies for chronic bronchitis, bronchodilators are very popular. And while theophylline is not one of our most popular bronchodilators anymore, it does make for a good test question. So what if that person is on theophylline? Why would I put them on a macrolide? Because patients with chronic bronchitis have a lot of mucus production, and mucus production in the lungs, great environment for respiratory tract infections. And macrolides are an excellent group of drugs to treat those types of infections. So if I put this patient on a macrolide and they're taking theophylline, the plasma levels of theophylline are going to be elevated compared to somebody who's only taken theophylline, but not a macrolide. That means a greater risk of side effects from theophylline. This is a drug which raises cyclic AMP levels. When that happens in the heart, you can get arrhythmias. And so that's how that patient may present, with arrhythmias based on starting them on a new antibiotic that raise the plasma levels of that drug. Now we're making one big assumption here. And our assumption is that metabolism inactivates the drug. If metabolism is converting theophylline from its active form to its inactive form, then a P450 inducer is going to lower its plasma levels, and a P450 inhibitor is going to raise its plasma levels. And that's the assumption that you should follow. When we come across some drugs that are prodrugs, keep in mind the opposite is going to be true. If it's a prodrug, the inducer is going to convert it to its active form more readily, and the inhibitor is going to prevent it from forming its active form. So that's a different scenario, but that is much more rare than what we're assuming here. If you look at the table listing all of the different drugs and all the different P450 enzymes there, down at the very bottom, you see a listing of P450 inducers and P450 inhibitors. Of course, there's a lot of inducers and a lot of inhibitors, but I want to give you a way to remember some of the most important drugs, the ones that are most likely to show up on your exam, and then let's talk about the possible drug interactions. First, for the inducers. If you come up with a phrase, and the phrase for me starts with smoking and drinking, sounds like we're having a good time, doesn't it? Smoking and drinking, because cigarette smoke has hydrocarbons which are P450 inducers. Drinking, because chronic ethanol is a P450 inducer. Now, where are we going to do our smoking and drinking? That's right, in Barb's car. So who is Barb? Barb is a barbiturate like phenobarbital. Phenobarbital is a classic inducer. Car, carbamazepine, one of our anticonvulsants, very popular drug. Notice smoking and drinking in Barb's car riffs her fin. Now, rifampin. Maybe my favorite inducer for your exam is rifampin, a popular antibiotic, anti-tuberculosis type drug, and then phenytoin an anticonvulsant. So those are my inducers. the hydrocarbons from cigarette smoke, chronic ethanol, barbiturates like phenobarbital, carbamazepine, rifampin, and phenytoin. Again, the inducer question is less popular on the test, only because the inducer is going to lower the level of the substrate, making it less effective. You know, the only time an inducer question becomes really, really exciting is if the substrate happens to be an oral contraceptive. Now think about that scenario. Why is that an exciting question? Because if you're on an inducer and an oral contraceptive at the same time, the levels of the oral contraceptive are going to be decreased. So how does that scenario end? That's right, in my favorite side effect, which is pregnancy. Pregnancy because of reduced effectiveness of the oral contraceptive. Now that's an exciting inducer question, so be ready for that one. Rifampin, very popular drug to think about in that interaction, but others could be used as well in that scenario. Let's look at the inhibitors. Again, more likely to see these. I use the mnemonic COKE to remember several of these inhibitors. If you're a fan of mnemonics, I like mnemonics. I think they're great ways to remember drugs and lists of drugs, but you have to be careful because sometimes students need mnemonics to remember their mnemonics, and so it can get out of hand. But COKE, notice, can stand for cimetidine, omeprazole, ketoconazole, and erythromycin. Out of those 4 drugs, clearly cimetidine is my favorite, easily my favorite. Cimetidine is an over-the-counter medication. Cimetidine interacts with a lot of drugs. So it's really more important to remember that one perhaps than the others. Omeprazole, also available over the counter, doesn't interact with as many drugs as cimetidine does. Ketoconazole is a possibility to show up on your exam as an inhibitor, though its use has really significantly declined in recent years. And erythromycin, one of our very important macrolides, certainly could show up on the test as well. If I had to pick 2 out of that list, cimetidine and erythromycin, watch out for those 2 on the exam. But what am I going to do with my Coke? Well, I'm going to mix it with grapefruit juice. Doesn't that sound like a good idea? Coke and grapefruit juice. Grapefruit juice, if you look in the note in the margin there, the clinical correlate reminds us that grapefruit juice has components that inhibit drug metabolism. And there's a list of drugs there that grapefruit juice can interact with. Perhaps the most important drug on that list is the drug atorvastatin. In fact, all of the different statin drugs that are HMG-CoA reductase inhibitors, those are very, very popular, very, very important drugs. First, start with a scenario. Why would somebody be taking a drug like atorvastatin? Because of high cholesterol, correct, high cholesterol. But what else do you recommend to that patient besides taking atorvastatin every day? You recommend that they change their diet, that they exercise more. Maybe you finally get a patient that will listen to you, and they decide, hey, I'm going to change my diet. In fact, a friend of theirs told them that grapefruit juice is very healthy, so they start drinking grapefruit juice every day with their breakfast. Tell me why that's bad for this patient. If they're on grapefruit juice has components that are P450 inhibitors. The plasma levels of your statin are going to be increased. Now, what is that patient going to complain of? Perhaps they're going to complain of muscle pain. Perhaps they're going to experience more muscle soreness because of high levels of the statin in the plasma caused by grapefruit juice. You know, it doesn't happen just from drinking the juice. You can eat grapefruits. If you eat grapefruit, you still get the components that can affect drug metabolism. So eating or drinking grapefruit, again, that can be a problem. Make sure you don't get grapefruit and grape mixed up. If the question says grape juice, first of all, that's kind of evil, don't you think? If it gives you both grapefruit juice and grape juice as choices, always pick grapefruit. That's the P450 inhibitor. But eating grapes versus eating grapefruit, it's grapefruit that you have to pick there. So I've got Coke and grapefruit juice. So I've got my drink. I need something to eat. So Coke and grapefruit juice with your pie. Now, PI, what does that stand for? Protease inhibitor. Protease inhibitors used for HIV because all protease inhibitors are P450 inhibitors. Examples of the protease inhibitors, drugs like ritonavir or indinavir, those drugs that end in AVIR. are protease inhibitors used for HIV, and they're all P450 inhibitors. Finally, a note about macrolides. Here's maybe a neat way to remember the macrolides and their effect on P450 enzymes. The three most popular macrolides, azithromycin, clarithromycin, and erythromycin. If you'll take the first letter of each drug name and put them in alphabetical order, you form ACE. What you've just done is you've listed your macrolides in order of the least to the most P450 inhibitor effect. In other words, azithromycin has the least P450 effects. In fact, it's the most popular macrolide. It's the most commonly prescribed of these drugs. It has no drug interactions. The macrolide with the most drug interactions is erythromycin. Watch out for that one, but don't forget that clarithromycin is also a P450 inhibitor. So you've got to watch out for the interaction between clarithro or erythromycin with other drugs. Other phase 1 reactions that don't involve P450 enzymes include hydrolysis reactions, where you're adding a water molecule to break bonds within those drugs. Examples: esterases, amidases. If I think about the enzyme called pseudocholinesterase, this is an enzyme that breaks down the drug succinylcholine. In fact, my clinical vignette reminds us that if you have a deficiency in pseudocholinesterase, then you're not going to be able to effectively break down succinylcholine, so you get higher levels of this drug. We'll talk about that in more detail in section 4, but this is a type of genetic polymorphism that can result in higher levels of succinylcholine. You also have monoamine oxidases, enzymes that metabolize endogenous neurotransmitters like norepinephrine and serotonin. These same enzymes metabolize exogenous compounds like tyramine. Tyramine is found in things like beer, red wine, cheese, and certain types of fish. We're going to focus a lot on tyramine later on in possible drug interactions, but for now, remember, tyramine is metabolized by monoamine oxidase. Alcohols are also metabolized, and there can be some genetic polymorphisms related to the enzymes in alcohol metabolism, which is why some individuals are more sensitive to drinking alcohol than others. They can't metabolize the alcohol as effectively. The other type of metabolism reactions are called phase 2. Phase 2 reactions are also referred to as conjugation reactions. And the word conjugation basically means that you're going to attach a molecule to the drug. Take the first example here of glucuronidation. I mean, what does it sound like? Glucuronidation, it kind of sounds like glucose. So you're going to take a glucose-like molecule and attach it to the drug, or you're going to conjugate it with the drug, and that's the idea. But in order to attach a molecule, a glucose-like molecule in this case, to the drug, you need an enzyme. And those enzymes are transferases. So make this connection. All phase 2 reactions involve transferase enzymes. So what's the enzyme that accomplishes glucuronidation? It's the enzyme glucuronylyl transferase. You need to transfer that glucuronide conjugate. There's a couple of clinical vignettes that I want to go over here that are related to glucuronidation. The first one is the drug chloramphenicol and its toxicity. If I said, what does chloramphenicol do to neonates? Everybody should identify that that drug can cause gray baby syndrome. But of course, that's the what question. What does chloramphenicol do to neonates? Gray baby syndrome. What about the why question? Why does chloramphenicol cause that effect? It's because chloramphenicol is metabolized by glucuronidation. And if you look at the bottom of the slide, it tells you that neonates have reduced activity. In fact, neonates have low levels of the enzyme glucuronylyl transferase, and so they can't metabolize chloramphenicol. The only time that you're going to have this type of an effect from chloramphenicol is when the levels of this drug really accumulate in the body. That happens in neonates because of an inability to metabolize the drug, and it shows up as this ashen gray appearance that we call gray baby syndrome. The second clinical vignette is a deficiency in this enzyme, known as UGT1A1. The GT is the glucuronylyl transferase. If you're deficient in this enzyme, you might get syndromes like Gilbert syndrome or Crigler-Najjar. These are syndromes that you would have covered in pathology, but help us to remember that glucuronidase is the enzyme that's deficient. Bilirubin, of course, is cleared by glucuronidation. So if you can't metabolize the bilirubin, you get an increase in the levels of unconjugated bilirubin. The third clinical vignette is a way to distinguish Crigler-Najjar type 1 from type 2. We can actually use the drug phenobarbital for this purpose. Phenobarbital can be used because not only is it an inducer of P450 enzymes, it's also an inducer of glucuronidation. Phenobarbital can increase the levels of glucuronidase. Notice, that would be beneficial for a patient with Crigler-Najjar type 2 because they just have a partial deficiency in this enzyme. But phenobarbital would not be helpful for a patient with type 1 because they have an absolute deficiency in glucuronidase. So a response to phenobarbital tells you that it's type 2, and the lack of response indicates that it's type 1. Other types of phase 2 reactions include acetylation. The issue with acetylation that is very, very popular on step 1 is that you can get genotypic variations in the population. There are fast acetylators and slow acetylators. Some people metabolize this drug very rapidly. We'll call those people fast acetylators, whereas others are going to be much slower to metabolize drugs by acetylation. The side effect that you've got to watch out for is drug-induced lupus. Drug-induced lupus happens in slow acetylators who take the drugs hydralazine, procainamide, or isoniazid. Hydralazine is the most popular test question because it's the drug that is most likely to produce drug-induced lupus. But importantly, it only happens if you're a slow acetylator. If you're slow to metabolize this drug, it's going to accumulate in the body, and that can result in drug-induced lupus. If you don't get a hydralazine question on your exam, you're probably going to get a procainamide question. This is that popular. And even though isoniazid is the drug that we discovered drug-induced lupus with, it's probably the least likely of the three to show up on the test. It's the least common in terms of occurrence of those three drugs. If you like mnemonics, you can come up with a mnemonic for the three lupus-causing drugs, and that mnemonic is HIP, H-I-P. You can come up with a phrase. You can say it's hip to have lupus. You can say HIP, H for hydralazine, I for isoniazid, and P for procainamide, the three lupus-causing drugs. You also have glutathione conjugation. We'll discuss this in more detail later on as we're covering acetaminophen hepatotoxicity. Since the drug-induced lupus question is such a popular question on step 1, you've actually got to be able to distinguish drug-induced lupus from non-drug-induced lupus, because these are going to have some features in common. Both drug-induced and non-drug-induced lupus, patient might experience a butterfly malar rash as shown in this diagram. Patients will have a positive ANA, anti-nuclear antibody test, comes back positive. Those are things that are not going to distinguish if it was caused by a drug or not. How do you know it was caused by a drug? Drug-induced only, you're going to see antihistone antibodies. So positive for antihistone antibodies says it's drug-induced. Perhaps the question does this. Perhaps you have a patient who's on multiple medications, and at some point they experience the symptoms of lupus. The physician decides to stop all of the patient's medications and observes that the lupus goes away. That's another indication that it was drug-induced, and you're going to be asked to identify what was the cause. Look back at the list of medications, identify one of those three lupus-causing drugs, probably hydralazine, as the cause of their drug-induced lupus.